Welcome back, my friends, to another episode of Pearls and Prep. We have a doozy for you today. We are going to talk about dystonias. That term that you're asking yourself, what do I do if I see a dystonia in the outpatient space? What is dystonia? How do I manage it? What does it mean? We're going to demystify that today with a mock patient case named Mario. Mario was started on risperidol. Within the last week, he's up to about 1.5 milligrams BID now for a first episode psychosis. He's coming to you saying, my neck is killing me. It's just twisting on its own and it won't relax. It hurts and it feels stuck. His neck is rotated to the right a little bit. He's got some tight muscle contractions. He doesn't have a fever. He's not confused. His vital signs are otherwise stable. He's mentally alert and anxious, asking if he's paralyzed. He has no trouble swallowing or breathing. You recognize this as an acute dystonia from risperidone starting recently. And if you're in the clinic and you have the tools to do this, intramuscular benztropine would be the way to do this. That would probably be about 2 milligrams in the clinic. Now, we're going to go into more of this a little bit later. I don't want you to focus so much on the specifics of Mario today. I want you to conceptualize this more broadly about what's happening, why it's happening, how often does this happen. That's really what we want to wrap our heads around today. Before we get into the nitty-gritty of how to treat this, I know we just mentioned the IM benztropine, but I want to get into an overarching definition of dystonia and what this is. So dystonia is a neurological movement disorder where muscles contract involuntarily, causing twisting, repetitive movements, or abnormal postures. Movements are often sustained or jerky. They can affect any body part, commonly the neck, the eyes, the shoulders, the jaw, or the limbs. It worsens with voluntary movement and with stress. You try to write with your hand and instead your wrist twists or your shoulder lifts without you really meaning to. Well, dystonia has Greek origins in its word, dys meaning bad or abnormal, and tonos meaning tension or muscle tone. So dystonia literally means abnormal muscle tone. We're talking about sustained involuntary muscle contractions causing twisting, abnormal postures, or repetitive movements. Some dystonias are medical emergencies. If the tongue, the pharynx, or larynx are involved, right, and we're hearing stridor or choking or airway obstruction, those are true medical emergencies. Patients need to go to the ER immediately for airway support. We're not going to focus too much on that today, but we are going to focus on a dystonia that lands in your office, and it is very uncomfortable, but not necessarily life-threatening. You always have to err on the side of caution, of course, and this one is pretty disturbing because it involves his neck and he can't really move or he feels paralyzed. So this requires immediate intervention. That's why we talk about intramuscular, 15 to 30 minutes. This will be more or less resolved with the benztropine. Now, we want to dig a little deeper here. Remember, with acute dystonias that are medical emergencies, they could look like a laryngospasm, involuntary closure of the vocal cords, right? An oculogyric crisis where your eyes roll upward for hours, very distressing, very scary, but it can be resolved very quickly, again, with IM or IV anticholinergics. The oculogyric crisis can be confused for or misdiagnosed as a seizure too. Just keep that in mind. And then, of course, you can have a neck dystonia, tongue, jaw, or throat spasms that risks the airway obstruction, difficulty swallowing, aspiration. So these could be very significant medical emergency. So just remember, when you start somebody on a high potency first generation antipsychotic or certain second generation antipsychotics, this is potentially on the table. Statistics show it's about 2 to 10% of individuals who may experience these acute dystonias. 2 to 10% gives you a rough estimate of what you can expect. Remember, the high potency first generation antipsychotics block those D2 receptors. They have higher affinity for D2 receptors. Their occupancy levels are higher for D2 receptors. Think of occupancy of receptors like parking spots. They park in more spots, so their occupancy is higher. Thus, they cause potentially high worsening dystonias or extrapyramidal side effects. The higher the occupancy, the higher the affinity. Affinity is more like a magnet. When you prescribe these medications, they have an affinity to the receptor. They're drawn to the receptor more easily. Those first generation antipsychotics have a little bit more affinity. So keep that in mind. But again, you have second generation antipsychotics that also have pretty strong affinities like Respiridol or Invega, which is the metabolic offshoot of Respiridol. We're going to go into that in more detail later. Dystonia is an abnormal, involuntary twisting or repetitive movement, an abnormal posture. It's a neurological movement disorder, jerky, sustained movements, and they can affect really any body part. So keep that in mind, and especially keep it in mind when we're talking about medical emergencies. Now, dystonia arises from abnormal signaling in the basal ganglia. It's a motor control hub of our brain. Normally, the brain sends a signal saying, move this muscle and suppress that muscle. In dystonia, the inhibitory suppression is broken. Too many muscles fire at once. That's an overflow muscle activation where muscles that shouldn't be involved contract. And that's a problem. Why is that happening? Because we block dopamine. First generation antipsychotics, high affinity for dopamine receptors, high occupancy levels, that goes ahead and blocks dopamine. And now your seesaw between dopamine and acetylcholine is out of whack. It needs to be a balanced seesaw between dopamine and acetylcholine. Dopamine so there's a key balance in this striatum, right? A nigrostriatal pathway. You've probably learned about this in school. And the key balance there is between dopamine and acetylcholine. There's a fine neurochemical balance. Okay. Now, dopamine in that particular brain region fine tunes and inhibits excessive motor signals. And acetylcholine excites motor signals. It increases muscle activation. So when antipsychotics block dopamine 2 receptors, the inhibitory brake is lost. And now acetylcholine goes unchecked and the seesaw's all the way up in the air and you have muscle overactivation or dystonia. So anticholinergics like benztropine jump in there and block muscarinic acetylcholine receptors, which reduces the excessive acetylcholine tone, right? So you have, in this case, Respiridol. Mario's taken Respiridol and dopamine's blocked. It has a higher affinity. Respiridol has a higher affinity with those dopamine receptors, higher occupancy rates at lower doses. And it's being blocked, and acetylcholine is overstimulated in those motor pathways, and hence his neck movements and his feelings of paralysis. Anticholinergics will restore the balance, and that's exactly why we want to give him benztropine to help his situation. Now, remember, with EPS symptoms, drug-induced movement disorders, acute dystonia is the one on your boards. They're going to ask you to potentially match these up, or on your tests. Dystonias are one of the first guests at the parties, right? They come between hours and days when you start a medication or when you increase a dose, right? So hours to days. Then you have akathisia, which comes days to weeks later and involves restlessness. Then you have parkinsonism symptoms, weeks to months, tremors, rigidity, slowness. And then you have the tardive dyskinesias, months to years, repetitive orofacial limb movement. So knowing the order of that, of course, is a very important pearl. The acute dystonia is hours to days. So be on alert. And it's one of those medication side effects you want to make very clear for your patients, especially with respect to the potential emergencies they might have to deal with. Now, we talked about Respiridol being a high D2 occupancy second generation antipsychotic, right? And we talked a little bit about affinity, and I just want to circle back that affinity is how tightly a drug binds to a receptor. It's usually measured in a KD value, and the lower that KD value, the tighter the affinity is. Respiridol, as we shared, has actually a pretty high affinity for that D2 receptor. Occupancy is how many receptors are actually bound at a given concentration. We talked about parking spots with occupancy. We talk about affinity, how tightly a drug binds to a receptor. I think of a sticky or like a magnet. Low affinity is loose. It binds and then it slips off quickly from the receptor, which can be beneficial at times with medications like quetiapine. Might be a different podcast episode. We can go into that later. Suffice it to say, these high affinity second generation antipsychotics, there's not many of them. Remember, the first generation antipsychotics, the Haldols, right? Those are usually the higher affinity for D2, where they really latch onto those D2 receptors potently. They occupy a lot of those receptors and hence cause muscle movements like the one we're talking with Mario. But again, second generation antipsychotics are not immune to this. You still have to be a little bit on guard, particularly with Respiridol and Invega. High affinity for D2 Respiridol. Respiridol binds tightly and it doesn't really let go. It leads to high occupancy, even at low to moderate doses. 70 to 80% D2 occupancy. That high affinity, high occupancy can definitely raise the EPS risk. Contrast that with something like Seroquel, which has a lower affinity for D2. It binds more weakly, comes off the receptor a little bit more often. It's what we call fast off kinetics. So it gets on the receptor, binds weakly, and slips off, which sort of helps a little bit because it's not blocking it as often and allows endogenous dopamine to bind there more frequently, which mitigates some of these movement side effects. It is fascinating to consider that the stickiness of these drugs on the receptors, some are just like a magnet that's airtight, it just sticks immediately. It's one of those magnets you're trying to pull off the refrigerator, and then you have the ones that kind of float there, like floating magnets. They come on and come off this little dance. They're a little more fluid, so you're not blocking D2 as strongly, hence why Seroquel might not block D2 as strongly, and it might not be the best antipsychotic in like florid psychosis, but its lower affinities kind of more of a, again, it's more of a fluid blocking where it's on and off that receptor, and that can mitigate some of the worst side effects we deal with when it comes to the first generations and risperidone. Very interesting stuff here with Mario. We have the tools to help him out. Before we go into that a little more, I also wanted to touch on second generation antipsychotics and why movement disorders typically aren't as significant as first generation antipsychotics and how that works out. It is interesting because second generation antipsychotics are usually buffered by their antagonism of 5-HT2A, because we know that 5-HT2A normally it's like a brake on dopamine in the striatum. And we don't really want dopamine to be pumped, like the brakes to be pumped on dopamine in the striatum. That's the whole problem, right? Because too much dopamine is being blocked. And when you block dopamine, the other edge of that seesaw starts flying, the acetylcholine, and you have muscle overactivity. So SGAs, they, instead of putting a brake on the dopamine, instead of agonizing 5-HT2A, they antagonize it, which actually releases the brake on dopamine a little bit, and boom, more dopamine in the striatum. It mitigates some of those movement side effects, right? But again, remember, this is all sort of a dance. It's a fun dance. It's an exciting dance. But risperidol has high D2 occupancy, so it's blocking D2 so forcefully, more so than those other second generation antipsychotics. So that buffer, that 5-HT2A antagonism, it's competing with more because risperidol is just really blocking D2. So that doesn't really help. And with Seroquel actually does go ahead and antagonize 5-HT2 a little bit. And that helps, right? That helps release a little more dopamine in the striatum and mitigate or lower some of those movement side effects. Very interesting. You have medications like Seroquel with their anticholinergic effects embedded in the medication, right? Which is neat because they have some muscarinic activity. Don't worry about muscarinic and anticholinergic. These are just ways to buffer against movement disorders even more. So when a drug like Seroquel has muscarinic activity and naturally embedded anticholinergic side effects, then we have this little embedded cushion in the medication that brings that seesaw back. Very cool way to mitigate this. If you're worried about anticholinergic side effects, we could even get rid of the risperidol altogether. You have to address his neck paralysis and neck movements right now because that is an urgent situation. We've got to take care of that now. After we give him benztropine and cogentin orally for a few days to make sure he's out of the clouds and monitor him closely, you may be able to actually switch him. If he says, hell no, I'm done with this medication, I'm not doing it, you could transition him to something like Seroquel. You have the anticholinergic effects embedded in Seroquel to bring the seesaw back. You have the 5-HT2A antagonism to encourage the dopamine release in the striatum. That might be more compatible. But again, there's trade-offs, right? Got that potent antihistaminergic activity, which can cause weight gain and sedation. So my friends, if you've noticed something about psychopharm, there's a balance, an elegant balance between everything. There's trade-offs. It's not as simple as this one's better, that one's better. Because if Mario already was 100 pounds overweight, it's problematic to transition him to a medication that might cause even more weight gain. And we go over in old episodes, the 5-HT2C receptor. And if you have a strong antagonist like Zyprexa, that's going to cause more weight gain. So you've got to really look at this and know all your receptors and what they do and why we choose them. It's so important. And if you're at all realize that I repeat stuff on this podcast, I do that on purpose. I repeat a lot of things because I find that's a good way to learn. I go over one thing in the case and then I repeat it again later because I recognize there's a lot of moving pieces here and it really helps to go back to things and come full circle. Now, Mario's getting treated. We have a little better of an idea of what's going on, the blockade of dopamine receptors in the striatal areas, the basal ganglia, and more broadly, part of his brain that affect his kind of motor control center, right? We're blocking dopamine. So we have an idea of why this is a problem. Risperidone is one of the more potent blockers. So what's a risk factor for dystonia? Let's pivot a little bit. Well, young people are more privy to it. They have higher dopaminergic tone. They're more vulnerable to sudden D2 blockades. Males, they have a higher baseline muscle tone. High potency or high dose D2 blockers, first generation antipsychotics, like we mentioned, as well as Risperidol or Invega, they tend to be a little bit more potent. Rapid titration. So if you're increasing, maybe you're in an inpatient setting and you're rapidly increasing an antipsychotic, guess what? That is also going to increase the possibility of these side effects happening and maybe would even warrant prophylactic use of benztropine. Now, that's not standard. I advise you all dig into the guidelines to get a more specific protocol here. I'm not advising that, but certain people, prophylactic anticholinergics would be wise. If someone has a history of acute dystonias, they're young and male, they're on first generation antipsychotics that require rapid titration, maybe that would be a good reason to prophylactically treat with benztropine, right? Some people give diphenhydramine 50 milligrams IM IV. Think about this and put it all together when it all makes sense in your brain. Now, we know that there's some of the side effects for the benztropine, also known as cogentin, dry mouth, blurred vision, constipation, urinary retention, and sedation. Serious or rare side effects, a paralytic ileus. Do your research, right? This podcast isn't everything, but just whetting your appetite for what you need to know. Some basic pearls, some good pearls. Sometimes we go into depth. You get my point. Now, what else do we want to know about acute dystonias, right? How else can we put this together? We talked a little bit about choosing an SGA with lower D2 binding affinity, fast off kinetics, that Seroquel magnet that kind of comes on and off of the D2 receptor, allowing for a little more endogenous dopamine to bind there, as opposed to this really stuck magnet where the endogenous dopamine that's normally circulating in your body is not hitting that D2 receptor because the magnet's so stuck to it. Switching to quetiapine or Seroquel might be an option. You have Latuda, strong 5-HT2A antagonism, which again, we talked about 5-HT2A and the releasing the brake on dopamine in the nigrostriatal pathways, also pretty cool. So think of these as a menu of choices you have based on your patient. It gets so fascinating, and I hope you're never intimidated by this stuff. It's always good to be humble and to know that things aren't so simple. This is a beautiful kind of art and a science. You have a patient in front of you who is so complex. We're all so complex. Patients who have certain genetics, they have metabolic differences in how they even metabolize these medications. Some of them are poor metabolizers of your medication, right? Maybe they are poor metabolizers and more of the drug is in their system for longer. These side effects get even worse because those receptors are being saturated by all this risperidol that's not being cleared out. I just want you to appreciate the elegance and complexity of all of this because there's so much going on. It's not just as simple as here's a med and here's what it's going to do to you. It depends on your genetics. It depends on your endogenous dopamine levels, right? It depends on the blood barrier penetration. That varies from person to person. The protein binding of these medications influences the concentration of the drugs and thus the side effects. Knowing that, although that could be intimidating, it could also empower you to understand, here's a medication. I have many different receptors. I have many different options as to what this medication is going to do and how it's going to exert an influence on each receptor. There's different brain areas, of course, and we're targeting different brain areas for different reasons. Opening the door, looking behind the curtain to understand these receptors and their pathways and how this all comes together is going to empower you to be able to execute treatment plans that are much more precise and intentional when you look behind the curtain and actually know what's going on. I hope you had a better idea of what a dystonia is, how to manage it, more specifically, why things are done at specific times, the receptor profiles. I encourage you to check out these SGAs, these second generation antipsychotics. Check out which ones have the highest affinity for 5-HT2A in terms of their antagonism abilities. Which med has the highest affinity for that? Which has the highest affinity for D2? And at what dose? Are some meds going to hit a high affinity for D2 rather quickly, like risperidol? Are some meds not? And why? These are fascinating, fun questions that you can dig into and really empower yourself with psychopharm. Mario did a lot better. We're so happy he's doing better. His dystonia has resolved. We actually ended up transitioning him over to quetiapine because risperidol was not a good fit for him. We did give him IM cogentin. We gave him some oral cogentin as well to bridge a few days later. Once we were able to safely taper his risperidone, we onboarded Seroquel. I won't go into the details of a cross titration. That is certainly not for this episode, but I am so grateful for each and every one of you who tuned in today. Don't forget to become Patreon members. You have access to beautiful slide decks where you can see all of this visually, evidence-based pearls to empower your practice. You'll get a bonus feed for bonus case studies and a bonus podcast. And if you can't do that, just donate a little bit, a couple bucks a month to the podcast. Definitely would love if you went to Apple and rated us 5 stars with a comment. That really helps more than anything. This podcast has gotten very big very quickly, particularly in NP circles for NP students. I love this field, and I hope you all do too. It's fascinating. You're learning every day, and I encourage you to spread the good word and email me in the show notes for any topics that you want covered, and I'm happy to cover them because it's all about learning and having fun. Take care, my friends. Signing off now. Take care. Bye-bye.